The MAIA study is a groundbreaking study, actually, which studied the effect of adding daratumumab first line in transplant-ineligible patients with myeloma. So this mostly people above the age of 65 onwards who are not eligible for transplantation. So the important point of the study is that the standard of care actually used to be Rev-Dex alone. The question was, if you add daratumumab with it, does it make it better or not? That is the fundamental question. And I think the answer is very clear-cut. The first paper on the outcome of DRD, that is daratumumab, Rev, and dexamethasone, was published in New England Journal of Medicine. And what we are doing here today in the VSH 2023 is giving an updated analysis on the efficacy and safety, and also overall survival, which is now extended up to more than 70 months, which is a long-term follow-up data. It's very interesting because it has shown a couple of interesting things. Clearly, the progression-free survival advantage of adding daratumumab upfront has been very well maintained, even in the long-term follow-up, which is a very important point. So clearly, patients are doing much better, actually, if you add daratumumab to a Rev-Dex. The most important thing, it has now shown a very significant overall survival difference. You cut the death rate by about 35%, actually, in the long-term follow-up data, if you're adding daratumumab upfront, which is very good for this population of patients who can't have a transplant. And the other thing is very interesting, I think we'll be presenting the data on, is about the discontinuation rate. Interestingly, the people who are on the Dara Rev-Dex arm actually stay on it much longer than people who are on Rev-Dex alone, which is counterintuitive because if you're adding 3-drug combination, it is expected that people will have more toxicity, which is not the case. Actually, they're doing much better, they're staying on longer, and they're living longer, which I think is very interesting. The only other thing to note in this group is that there is a higher intensity of signal of infection rate in this population, but it is actually very manageable. And this is something I think the clinicians are aware of, and they're already doing this. Overall, I think the role of daratumumab is very well established, both in upfront and in the relapse setting, particularly in this transplant-ineligible group, which is the majority of patients with myeloma. It really has transformed the landscape for the better.